Rob was nice enough to give us some time to talk about our take on the state of the industry and kind of what is West Wireless and what is our state of play. It's serendipitous that we actually have two major announcements to make today, so we can do that. And we're excited. So just a little agenda, what is the state of the industry? I do think that we're going to look back on 2010 as one of those seminal years in healthcare. And I'll try and give you some examples. And I'm actually going to challenge everybody in the room today that there's been a seminal change in the landscape in U.S. healthcare. And I wonder if our industry, as young as it is really ready to react to the change and actually lead the change. So we'll have a little fun with that. If I say the word solutions once versus technology, I will have clearly missed my mark. Talk a little bit about advocacy over the course, and then what are we doing at West Wireless. It's really interesting. I think if you were to ask people in the room what is the biggest challenge in healthcare, you'd probably get about 10 answers. But if you think about the last 150 years, it's healthcare kind of falls around three core ideas: quality of healthcare, access to that care, and then what does it cost? So if you look at, basically over the last close to 175 years, think about most of the challenge was how do we get higher quality costs, everything from how do we make sterile operating rooms to how do we introduce things. And there's been huge technology leaps, whether it's small molecule pharmaceuticals, biologics. I do think that we're about to step on into a whole era of kind of data-driven medicine, which will be as profound as what we saw with the advent of medical devices and pharmaceuticals. And if we're to have this conversation in 25 years, I do think people are going to be talking, there's consumer-driven stuff, there's pharmaceutical-driven stuff, there'll be medical devices, but I also think there'll be a whole new idea that's basically called data-driven medicine, so as we go through that. So we'll talk a little bit about that as we go through with it. What is West Wireless? And actually it's great, as you look out in the room, West, obviously I'll talk a little bit about Gary in a second, but one of our original co-founders, and Paul and Don Jones are in the room, and Brent Eastman from Scripps. So we're always grateful to say thank you to Scripps and Qualcomm. And as we've grown and evolved, they've been great partners to us. But what are we? We're an independent, not-for-profit medical research organization. We're a little over a year old. And we have basically one focus, which is how do we lower healthcare costs? And we think that's actually the most significant challenge facing the industry today. And if you take the U.S., 20% of GDP, people are saying 17.9, 18.0. I'm not sure anyone in the room believes that with the passage of the healthcare reform that we're going to see a dramatic bending in the curve. So we're kind of at the point, an inflection point where 20% of the economy now goes toward healthcare. All right, and we think that's pretty much about the limit as to what the economy is going to be able to spend for healthcare over the long period of time. Demand for healthcare, particularly if we'll just stay U.S. focused for a second, where we just added between 18 and 25 million people to the healthcare rolls, coupled with an aging population, is going to put a tremendous amount of pressure on the infrastructure. But the biggest pressure it's going to put on is costs. How are we going to pay for all this stuff? Where are we? I think we're an early stage industry with huge potential. I mean, when we're in The Economist and in the science of translational medicine, both these publications appeared in the last 30 days. It's great. But to be honest with you, I'm a little critical of the industry from the perspective that we've been talking about the birth of the industry for 10 years. I remember having initial conversations with some of the early people in the CRM business, the cardiac rhythm management business, who were creating CardioNet and other things. And that was wireless, and if you look at where we are today, despite the tireless efforts of people like Don and others, we're still an industry about to give birth. Well, at what point do we stop talking about potential and start talking about real benefit that we're bringing to the healthcare system? All right, and the reason for that is, in my mind, look, we can talk about regulatory, we can talk but a lot of it is, to quote the eminent Jerry Maguire, is, show me the money. I mean, where is the business model and how are we going to move forward? All right, one discussion about the industry, all right, and I grew up in Johnson & Johnson, where there wasn't a healthcare widget we didn't love. Paul, I envied your presentation because you had the cool toys. I mean, now if you were a hardcore device guy, I mean, you'd be showing up with your titanium hip. You'd show a new contact lens that actually would give you a 25 vision. it was the toys. And it's really interesting. If you think about our business and our industry right now, we're very focused on the technology. And I asked the question, what problem is the industry trying to solve? In some ways, you almost get the sense we're a technology looking for a problem, as opposed to what is the problem that we're facing and what solutions can we uniquely offer through wireless, right? And how do we provide, and this is the key for the entire presentation, how do we provide a low-cost outcome based on a complete solution versus how do we offer a remote monitoring device? I mean, I'll pick on the diabetes guys. If CTIA, if you were at the pavilion, you saw no fewer than 6 people who found a way to wirelessly enable a glucometer through a variety of technologies. And some people have done blood pressure cuffs, and it was really cool because you can now take that data and you can push it somewhere. And if you were to talk to the government, if you were to talk to United Health, if you were to talk to other people, they say it's really cool, but who cares? I mean, okay, so great, you got a glucometer that can push data from point A to point B. I've now added $100 to the cost and the challenge there. I don't think we were focused on what does the solution look like. And the little circle, if you haven't been up to our institute, this circle is featured prominently every place where, how are we looking at a holistic solution that has 4 basic components, which is, there's a physician, there's early intervention, and we're going to generate data somewhere along the line, and then we're going to push it out to somebody. And the other question I'd have to the big macro question, are we offering technologies or solutions? Second big question is, what's the value of the data? It's really interesting. Rob, I was so happy to see providers here today, but I challenge you, where's IBM, where's Tata? Where are the big people who understand huge amounts of data? Because the interesting issue is we're going to have remote sensors. I mean, Paul, the stuff you showed today is astounding. But literally people are going to throw off a terabyte worth of data from remote sensors to somebody. Okay, now if you were, I can see my colleague Joe Smith. Joe, if you're a doctor and you're instantly getting close to a gig worth of data on a patient on a daily basis, are you marginally excited about that? It's just it's a thought process. It's great that we have the providers here, but we have to begin to think about what is the data going to be, because the data eventually is going to be predictive, and predictive data is going to allow us to intercept the cost curve a little bit earlier. All right, significant barriers to the industry, and look, I think we all have to solve the reimbursement problem or implement a different business model. I'm going to err on the second. A statistic that AdvaMed, which is the Medical Device Association, put out 2009 marked the first time in 15 years that there had been a decrease in venture capital going into the industry, and it was not an insignificant decrease. It was actually, the numbers they were quoting is 3.3 billion going down to 2.1 in 1 year. And the first quarter 2010, the flash numbers I was getting from Jim Meza, who's over there, they've talked about another decrease of about 17% from a 30% decrease in 2009. So, until there is some idea that there's certainty in the business model, I think we have a significant challenge of getting funding around early stage technology. So we have to think about that. If anyone could tell me what the regulatory pathway is around a remote medical device, remote monitoring medical device, I would be more than happy to put them up in the San Diego at the hotel of their choice for weeks on end. I think we've had an unfortunate set of circumstances where we have the FDA with virtually no incentive whatsoever to provide any clarity. And to be honest, I'm very concerned that the FDA has no incentive right now to think through anything other than we're here to protect patients against people like that are assembled in this room who are for-profit people, entrepreneurs, who are basically going to try and take advantage of somebody in a moment of weakness. So one of the things that we have to do, and I know Qualcomm and other people have been tireless at this, but we have to begin to message that what we are all about is we are low-cost solutions that need some enlightened policies. That's absolutely one of the roles I do think that we can play and our advocacy efforts need to focus on. Absent clarity, we are going to see a profound lack of innovation, and absent innovation, we are going to have a significant challenge overcoming the healthcare crisis that we're all facing into. All right. Other outstanding legal concerns, privacy, liability, practicing medicine across state lines are challenges, and I think we have to work on those individually. But If we could wave one magic wand across the board, I would ask for clarity from a regulatory environment perspective, because I think a lot of other things that we can overcome. Here are two of our favorite charts of why you should be excited about the industry. Okay, we talked about the problems, business model, we got some government problems, but let's look at some basic facts. This is the American Association of Medical Colleges, and actually published by our friends at the New York Times, so that means it's the God's honest truth. But if you look at it right now, any way you slice it, there is close to a 25,000 physician, GP, physician shortage in the United States today. 25,000. When you add 18 to 25 million people to a fixed base of physicians and hospitals, to quote an early astronaut, Houston, we have a problem here. And you can see that doesn't change over time to the point where 2025, and we'd all like to say 2025 is going to be somebody else's problem. But to be honest, we are all going to be accessing healthcare in 2025. And with a shortage of 150,000 physicians, that means there are going to have to be ways that we force extend or force amplify the existing physicians. It means we're going to have to de-skill healthcare so that we use the specialists for people who need specialists. But we are going to have to create smart systems that will enable somebody who isn't an expert to at least manage self-imaging that gets passed to an expert or something like this. There's just simply not enough people that are going to exist. The second issue is, as much as the baby boom generation is the toughest generation that's ever existed and is going to suffer all the pains of aging gracefully and without protest, it's a good chance that somebody who's 60 is going to consume more healthcare than somebody that's 20. And if you look at 2010, it will mark the first time in North America where there's actually going to be more people over the age of 50 than under the age of 50. So we're going to have a inherent demand. So if you look at it, shortage of doctors, more healthcare being demanded, 18 million people dropped into the healthcare system without an expansion. So I'd say, the fundamentals are good. What we'd love to see is kind of coalescing around the idea of infrastructure-independent healthcare. Think about the healthcare system today. It was basically built around acute care situations, right? You have a fixed capital base with an expert. You would go there to get your care. Joe Smith, I thought was very eloquent today, that the doctor would say, take 2 Band-Aids, which is a registered trademark of Johnson & Johnson, or take two things and come back to me in 6 weeks, no magic to the 6 week, no magic to why you're coming back. So you think about it, it is a low-touch, high-expert, capital-intense model. The model that we think is the reason that wireless health offers such promise for driving great outcomes while lowering the cost is we think it can be a high-touch. One of the most significant healthcare innovations is probably the Take Care in Minute clinics. You saw that. State by state, you now have put nurse practitioners in a position to frequently interact with people on a disease space, but they're going to need to do diagnostic work. Pretty interesting discussion. It's not going to be high touch. What's the right treatment? The interesting, Eric Topol talked today about we're all going to do some form of genomic work where we're going to understand, Rob, you shouldn't be taking Plavix because you're one of the 33% of people that it's just not going to work for. By the way, there's going to be some monitoring that's going to come across in the next 10 years that's going to say, oh, by the way, even though you're one of the 67% of people that we thought could take it, we're not seeing any reaction. And how do you titrate the dose? So right treatment when they need it, as opposed to when we will schedule you to get our services and where they are. So infrastructure independent in our mind is high touch, it's right treatment when they need it, where they are, and bottom line, it has to be addressing lower costs. In my mind, we have to shift the customer. Every pharmaceutical company and most medical device companies are run by people like myself who grew up carrying the bag. It's a badge of honor. If you weren't a pharmaceutical rep that had the big square bag that at any given time you could take out a refrigerator, out of your bag, but you would roll this thing in and say, okay, it's a pretty standard thing. I got to be nice to the nurse, so I'll take out some Tylenol, maybe a bag of bagels. I'm hoping that I'm going to grab the doctor for 35 seconds and Dr. Jones, have I got something for you today? And you would have your 3 sound points done. Never a conversation about outcomes, never a conversation about cost. And this goes on pharmaceutical, and this goes on medical devices. Okay? Well, unfortunately, the world changed when we can no longer afford to give all the health care that everybody wants when they want it. All right, so the business model of most major medical device and pharmaceutical companies predicated on an individual practitioner making a decision that has no cost consequences. When you get into a mode, which we are now, where 20% of the GDP is spent in healthcare, other people are going to intrude on this nice little conversation. And this kind of happened a little bit where, gee, Dr. Jones, I've got this thing. Now the doctor might say, is it covered? You know, so we're kind of getting a little bit thing. Now I would have a little fun with the doctors. Are they asking it, is it covered because they're concerned about the costs, or they just want to know that they're going to get paid? And it's not about the level of care necessarily, but this idea that there is, you know, is it reimbursed or is it not reimbursed is starting to enter. Innovation has not been focused on delivering lower costs. It's been focused on what can we get for it, all right? So we've been very slow to move from that. Increasingly, payers and governments are shifting emphasis from products and outcomes. I know everyone read all 2,000 pages of healthcare reform, and you probably noticed the accountable care organization and the medical home stuff. I think it was on page 1867, and I think the other one was like 2117. But these two things are going to be perhaps the most significant changes we're going to face, where basically somebody is going to be in charge of looking at the entire cost of care for an individual as they face a particular challenge. All right? Big, big changes. So this accountable care organization, medical home, are going to be implemented between now and 2014, which represent a significant opportunity, because if all of a sudden somebody said, hey, Rob, you're now in charge of Don's Complete Health, the person who's running the accountable home, the accountable care organization, has no clue what Don is doing other than what they're seeing for a specific instance of care. So unbelievable thing. A word that we should all get very familiar with that nobody will ever utter is the word capitation. All right, everyone knows what capitation is? All right. Decapitation. You know, it's interesting, Paul. I've experienced that several times. I'm hoping to avoid it over the course of the next year. But
talk about capitation.
Capitation. Well, capitation is really interesting. I mean, in the entire healthcare debate where we just spent $1 trillion over the course of the next 10 years, did the word capitation ever come up in the debate? No, because the minute anyone ever said, we're going to capitate your healthcare costs and the rest is going to come out of pocket, the Tea Party movement would have been, you know, an appetizer for the super caffeinated movement of throw all the bums out. If somebody literally, you know, leveled with the American people that says, guys, you know what, there's going to be capitation. We're going to spend, Paul and you, we're going to spend $5,000. And it's going to be up to you to help us choose where that $5,000 is going to spend wisely. I think we would have had a different outcome. But you know what? Healthcare passed. And as an outcome of this, there is going to be capitation, which presents an enormous opportunity. This is a discontinuity unlike anything we've seen in healthcare. It almost, if anyone who's been in healthcare since like 97, when remember the HMOs came around, remember that? Oh my God, the HMOs are going to change everything. Well, they didn't. They actually just messed things up for about 2 or 3 years. But you know, this is a redo. All of us had to get ready to sell to HMOs and PPOs. We have a tremendous opportunity where there's a huge discontinuity in the market that we have to take full advantage of, and it's called capitation. So I would argue when I keep talking about, let's not talk about technology, but let's talk about solutions. The solution, somebody's going to say, and I think this very conversation has been had in IBM, where they've looked at their large payer called United, and they've said, you know what, we're only going to spend X on preterm labor. We're only going to spend Y on somebody with asthma. And United raises their hands and says, well, you know, geez, what if it costs more? And somebody's going to turn around and say, that's kind of your problem. You want our business? We have 400,000 employees in the United States. It's going to be up to you to cover it. So I think there's significant changes coming. All right. I would argue, and we've had the privilege at the Institute, we've had 30 companies come and visit us in the last 2 months. And every single one of them sat and says, geez, if only CMS would get on the bandwagon. You know what, guys? The earth is round, the sky is blue, CMS is going to get around to reimbursing us correctly on or about 2025. We could argue about it. We can all, Paul, can we borrow the jet and can we all go storm CMS headquarters? They don't care. I mean, fundamentally, if you look at the demonstration projects, what is a demonstration project? Oh, we're going to figure this out. All right, so it's 18 months of public comment, right? It's 12 months to implement, 18 months to read. 18 months to argue about it. 7.5 years from conception of demo project to when there's a change in the system. To be honest, in 7.5 years, I mean, just look at the technology, Paul, you showed today versus what it's even going to be in a year. Do we really think that our industry is going to sit around and wait for CMS to spend 8 years? But rather than waiting for that, I would challenge everyone in the room, and the checklist, if I was a venture person, that I'd ask, have you talked ex-US? You know what? Primary care trusts in the UK, very different approach. You look at France, you look at Germany, you look at Japan. All these countries have basically a single payer system that understands if I am going to have to manage the cost of somebody over a lifetime and will pay for secondary prevention. Yet we're all going to sit here and we're all going to hold hands and say those bad people at CMS. Well, it's ex-US, we're a global business. Second point, large self-insured employers. You can't have the uncertainty that a huge chunk of your costs on any given time period are going to be variable to the point of, gee, it could be going up 2, it could be going down, it could be going up 8. It's just unacceptable over time. So these large self-insured people who understand that they are going to have an employee population for more than 3 years are going to be willing to invest in prevention around high cost, high risk patients and diseases. All right, and it was one of our companies, which will go nameless, had a great conversation with them. I asked them, what's the number one business challenge? Well, we can't expand the number of reps we have calling on cardiologists fast enough. We already have 600, we need to get to 800. I said, well, who's calling on United? Who's calling on Aetna? And well, why would we call on them? The doctor's going to make the individual decision. It's like, that's a big swing and a miss. Instead of your 200 people carrying the bag, why don't you spend 5 to, really going to call on the payers and understand that. So large self-insureds, the IDNs, our mantra's got to be Intermountain Health, Kaiser, Geisinger. Large integrated, the VA is another one, where these people are all very interested. And Rob, it was great to see some payers here today. And we literally had Paul from United get up to say, we desperately want to invest in your technology if it can save money. And I also think we heard the words, we can't have it both ways. If we ask for it, we're going to have to pay for it. So I would challenge the group to let's not have life revolve around CPT codes and CMS reimbursement at a premium to what exists today. And I think if we follow that formula, we will be able to at least become revenue positive around a lot of the companies that we're talking about. And if it's revenue positive, I do think we'll all be in a better place than we are today. All right, just the questions I'd ask, when do patients become expensive? Everyone talks about prevention. I'd like to add another word to prevention. It's called secondary prevention. It's not even the most enlightened government or company is going to pay for somebody 17 to try and keep them healthy for the rest of their lives. But what we confuse is the word prevention with secondary prevention, which is I already have diabetes. It's when I get diabetes and hypertension and cardiovascular disease is when my cost goes from $4,000 a year to $10,000 a year. So focusing on this idea of secondary prevention where you've already identified somebody who is at risk, right? Let's not give it to everybody. Let's find somebody who is at risk and spending a little bit more to save on the cost curve on the back end is probably where that needs to be. But figuring out what patients are the most expensive. All right, what would a caregiver pay for out of pocket? A caregiver could be a payer, could be your mom taking care of you. What would they be willing to pay out of pocket? Because ultimately, we might be in a circumstance where there are significant chunks of consumers that would pay for the benefit of health. If you've ever run into a parent of somebody who's a type 1 diabetic who needs to manage their insulin the first time they go to school, that parent will literally tell you that is the worst day of their life because the child left. You have no idea whether the child is going to have the confidence to whip out something, prick their finger, and do their testing because other kids might think they're a little bit weird or sick, right? So it's a horrible day. If you were to talk to that parent, would they pay $1 a day for the ability to understand whether their child's insulin is being managed correctly? So, what would the caregiver pay? All right. Understand the side of care. I think, to echo what Brent said, right now I think we're very unsophisticated in understanding where costs actually occur. If costs occur in a hospital, can we move it to an assisted living facility? If it's in a nursing home, can we move it downstream? All right, this whole idea of infrastructure independent is predicated on the idea of let's move somebody out of some place where you're spending a ton of money monitoring that person 2 to 3 or 4 times a day. And how do we do that? Through the technology we're going to develop. All right. And the last point is is there a different model that intervention can be proven to lower costs? Because I do think our customer is going to be the big payers, and their language is going to be, sure, you're going to have to deliver an outcome. Look, the easiest way to lower healthcare costs is deny healthcare. That's not what we're about. I think our industry's got to stand for, we're going to give you healthcare, but we're going to do it in a different way that's going to move the site of care, and we're going to find a different model for innovation that's going to lower cost. Is the end game to digitize and automate an existing process? So when we're putting dongles in the end of glucometers, all we're doing is we're digitizing something that actually works reasonably well. So do we need to look at the idea that we're going to use digitization to either move site of care, move to a less skilled healthcare worker through the benefit of knowledgeable algorithms? And can we look at digitizing as a way of creating a whole lot more information? All right. So I think we've beaten this point to death. Think solution versus technology. Focus on, when you guys are sitting in evaluating whether you should be investing in this company or that company, first question you should ask is, what is the payer going to think of that? All right, and then think of solutions. I mean, actually you guys would know, Don, probably better than I. What was the first MP3 personal music player out? I don't even know. I remember like the little Rio thing, or whatever it is. It was around 2 or 3 years before our friends at Apple showed up with an iTunes. iTunes is a solution, right? Diabetes management versus a Bluetooth-enabled SMBG, all right? Arrhythmia management versus a wireless continuous EKG. I mean, wireless continuous EKG is really cool. I mean, it really is. We've seen some really cool pictures. But unless you're applying that to the idea that we're going to use those continuous pictures to actually begin to understand algorithmically that this patient is facing a problem, is all we're doing is we've automated something that the doctor could literally walk in and look at. Right? Advocacy and policy, coordinated efforts, carriers, manufacturers, and venture capital, I think that goes without saying. The groups that I don't think we've involved that we need to is patient advocacy groups. I mean, it's really interesting. I've had the experience of being a grubby manufacturer, for-profit guy going in to talk to some pure as the driven snow congressman, and they explain to you instantly, well, you're trying to make money off people who are sick. You know who they don't say that to? If you have a patient advocacy group, which could be, look, I want to be the aging in place baby boomers or something like that, they're not going to argue. When you're a constituent, not going to argue with you. So we need to get the patient advocacy groups going. The payers have the same interest that we do in creating regulatory clarity and reimbursement clarity. We have to involve them in our efforts. I would argue if we want to have a fight about reimbursement, if we really want to have a fight, let's not have a fight to say, I think we ought to do all remote health. Let's pick a few conditions. Let's pick a high cost, high risk, high visibility patient. It's really interesting. If you looked at the UK elections, David Cameron became the hero of the national healthcare system. Why? Because he promised he was going to put £1 billion extra treating oncology. Now, he did a bunch of other stuff that, it was a little bit sleight of hand. But if you look at oncology in this country, nobody has ever denied reimbursement for an oncology drug. Why? Because this person's got cancer. So this goes back to the idea, if you focus on a foot of the door approach, it's like diabetes. The government now will reimburse for pumps, and they'll reimburse for continuous glucose monitors. Right? They did it because it's type 1. It's type 1 diabetics with kids. That's clean, that's safe. So again, I think we've got to be coordinating our policy efforts. Okay, what is West, and what are our core functions? Look, we're about innovating, validating, advocating, and investing. Innovating, we're going to do internal and external R&D, which whether it's a partner that comes to us and say, could you help us develop a wireless application for this, versus there are categories where we think that there is no industry-led research going on, we will do that. We will take that through proof of concept and clinical and early commercialization. Obviously, as a not-for-profit, there will be challenges to how far we could go to commercializing things. All right, validating. Eric Topol and Joe Smith lead our group around clinically validating, and we feel that there's a tremendous amount of expertise in how you develop a good healthcare economic-oriented clinical, which we can certainly help with, and we can certainly help aggregating as kind of a best practice place there. Advocacy and policy, it's very interesting. Some people who we could probably never see as an industry will certainly see a not-for-profit, so we hope to play a unique role in, for instance, I see no reason why Gary can't go in and yell at the FDA. You guys can't do that, but if they get mad at Gary, all they're going to do is they're going to withhold care. So we will have a presence in Washington, and then we will be in a position that we will be evaluating internal and external opportunities and look forward to funding some of the most promised because, again, Gary and Mary have had the vision of how do we serve as a catalyst for the industry, and one of the biggest challenges for the industry right now is lack of funding. We have two really exciting announcements today, and actually I'm just going to embarrass Gary because he saw the presentation without this in, but Gary and Mary announced actually today that they're putting an additional $20 million into the West Wireless Health Institute, and it's basically to fund all our engineering work, which is led by Mary Marigami, who is sitting next to Gary. But this really goes to, Gary and Mary had put up the initial funding to see if they thought that they could make a difference, and then are so excited about what they see as an industry that can have a profound effect on lowering costs and really helping change healthcare in the United States that they've come back in with another $20 million. So Gary, on behalf of the Institute. Now, Paul, I could being that Gary really doesn't like to be publicly acknowledged, that capitation thing could be a problem here. But again, Gary, we thank you. And today, we're also very proud to announce what we call a technology and education partnership with General Electric. Obviously, one of the best names in healthcare is looking for how do they take their wireless strategy in a different direction. And we've been spending a fair amount of time together focusing on how we can collaborate to look at new business models and new technologies. While we can't talk a lot about the specific areas, we're ecstatic that one of the best names in healthcare is going to be collaborating with us. And again, it really talks to the ecosystem that exists in this room, and we look forward to helping GE really change some of their business strategies and business models and look at wireless in kind of a different direction. We're a year old, and what have we done? We've been certified as a medical research organization. We have a San Diego's headquarters. Actually, we were trying to figure out if there was a way, we couldn't walk right up, but we're literally about 400 yards up the street. We have an executive team. Gary is nice enough to say it's a high-quality executive team. I'll ask you guys to judge us in a couple of years. Engineering team has begun, internal R&D. We have a wonderful collaboration going on with a lot of people that we're hopefully going to push out the door. And as a matter of fact, Marin, what are you doing here? We've got stuff to push out the door, don't we? He heard there was a free lunch, so he took some time off. Again, we're very grateful for the $20 million in funding and GE announced today. So we feel like there's a little momentum, and we really hope that the best for the industry is yet to come. So again, if I leave you with nothing else, how do you focus on a solution that delivers lower cost, and hopefully West Wireless can be helpful there.